Hello, my name is Yuval Singh Singh, and today I'm going to discuss case study on CHF. Here is our case study. Here are the lab results. Let's discuss the subjective data. So the patient is a 67-year-old female who came to the emergency department. Patient states she feels like she's running out of her breath and her legs are getting bigger every time she looks at them. Patient said she is following a fluid and salt restricted diet, but she gained 1 pound a week over the last 2 weeks. Subjective data continued. The patient denies fever, cough, nausea, vomiting, diarrhea, chest pain, pressure, palpitation, wheezing, sputum production, abdominal pain, and abdominal distension. Patient reported trouble in breathing at rest, feeling chilled, requiring blankets, and mild fatigue, forgetfulness, incontinence, increased urinary frequency, and bilateral lower extremity swelling with the new onset and worsening. The patient said she did not get out of her bed for several days except to use restroom due to feeling weak, short of breath, fatigued, and patient said there are no ill contacts at home. Subjective data continues. Patient has a family history of heart disease. Her social history is positive for smoking 30 packs every year. Due to increased shortness of breath, the patient quit smoking 2 years ago. Patient denies any use of alcohol or illegal drugs. The patient reported no non-allergy to drugs, food, or the environment. Patient has a past medical history of COPD, coronary artery disease, myocardial infarction, hyperlipidemia, hypothyroidism, hypertension, peripheral vascular disease, obesity, diabetes mellitus, and tobacco use. Patient surgical history includes hysterectomy, cardiac catheterization with stent placement, appendectomy, and nephrectomy. Below is the list of medication taken by the patient. Objective data: the patient vital signs are blood pressure 170 over 85, pulse 126 beats per minute, respiration 27 respiration per minute, temperature 36.9 degrees Celsius, and O2 said 92% on room air. CBC and chemistry panel are done. The doctor writes the following order. He also writes laboratory order for CBC, electrolyte, INR, and doctor instructs us to monitor daily weight and to monitor intake and output. Let's discuss the pathophysiology of the CHF. It is evident from the patient syndrome that she is suffering from CHF. CHF is a complex syndrome in which the heart muscle is not able to pump blood adequately to meet the requirement of the body. This results in the backing up of blood, and fluid can often build up in the lungs, which can result in shortness of breath. Congestive heart failure is a syndrome that can occur secondary to any disease that causes the impaired ejection of blood to the systematic circulation or ventricular dysfunction. The right ventricular failure causes abdominal and peripheral fluid buildup, while the left ventricular causes left ventricular failure can result in fatigue and shortness of breath. The neuroendocrine system is stimulated by the decrease in cardiac releases the hormones, which cause increase afterload due to vasoconstriction. The increase in afterload causes an increase in myocardial contractility, which prevents myocardial relaxation, which increases the demand for a myocardial oxygen. The decrease in cardio output stimulates the RAS system, which leads to increased salt and water retention and vasoconstriction. Let's discuss the relevant laboratory and diagnostic tests. If the patient is suspected of having a congestive heart failure, the physician will order CBC, electrolytes, INR, BNP, PTT, burn, sputum creatinine, electrocardiogram, echocardiography, CT, and MRI. The CBC measurement of hemoglobin, platelet hematocrit, and WBC count helps to know the risk factor related to heart defects. In our case study, patient has normal levels of WBC, hemoglobin, and hematocrit. The electrolytes, abnormality of electrolyte is common in CHF. It happens due to result of diuretics or impaired renal function. In CHF, potassium and sodium are important to monitor, while chloride levels are also affected by CH. In our case study, sodium and potassium levels are within normal range, while chloride levels are on the lower side. It is essential to check sodium levels, as hyponatremia is common in patients with CHF due to discharge of free water via dilution hyponatremia. Monitoring potassium is essential, as treating CHF with hypokalemia, complementary diuretics can cause potassium abnormalities. Also, hyperkalemia can occur due to potassium sparing diuretics and potassium supplements. BNP is used to diagnose congestive heart failure. This test determines if the heart is pumping blood well enough to body part and assess how hard the heart works to transfer blood throughout the body. High burn and creatinine levels are associated with patients with CHF and renal dysfunction. Iron is also important. Echocardiography, electrocardiogram, and CT scan, MRI, are other diagnostics that are used to detect CHF. Let's discuss the modifiable risk factors related to CHF. These are smoking, diabetes, high blood pressure, physical inactivity, being overweight, high blood cholesterol, alcohol use. Let's discuss non-modifiable risk factors related to CHF: age, ethnic background, gender, heart valve disease, coronary artery disease, heart attacks, family history of disease. In our case study, modifiable risk factor for the patient is that she is a past smoker, has a high blood pressure, diabetes, high blood cholesterol, obesity, and physical inactivity. In contrast, the non-modifiable risk factor is her age, as she is 60, and people above 65 are at a high risk of getting CHF. Her gender, females are more prone to get CHF. Her history of heart valve disease, her history of coronary artery disease, and her history of heart attack and family history of heart disease. Let's discuss CHF effect on other body parts, respiratory system. It causes pulmonary edema. CHF often causes pulmonary edema. In congestive heart failure, the heart cannot pump efficiently, which leads to a backup of blood into the veins that transfer blood through the lungs. Due to increase in pressure in the blood vessels, the fluid is pushed into the air spaces in the lungs, which reduces the movement of oxygen through the lungs, due to which person experiences shortness of breath. Let's discuss CHF effect on renal system. It causes kidney disease. CHF increases the risk of kidney disease. Heart job is to circulate blood throughout the oxygen blood throughout the body. The heart becomes congested when it is no longer pumping efficiently, which causes a buildup of pressure in the central vein connected to the kidney. This results in a reduced supply of oxygenated blood to the kidney. When the kidney do not get adequate amount of oxygenated blood, they are not able to work efficiently to remove excess waste and water, and this results in edema in legs, ankle, and feet. Let's discuss our nursing plan diagnosis. Our first priority problem is ineffective breathing pattern related to pulmonary congestion, secondary to congestive heart failure, as evidenced by weekends free oxygen saturation of 92%. And a respiration rate of 27 respiration per minute and shortness of breath. As the patient status, she is running out of breath. The reason behind is that if the patient does not receive proper treatment for an ineffective breathing pattern, it can result in respiratory failure. So treating inefficient breathing pattern is a priority, because restoring the proper breathing mechanism can improve patient outcome and overall well-being. Also, enhanced breathing pattern will promote comfort and ease of breathing, which prevents the risk of skin and tissue breakdowns and syncope, and maintain acid-base balances. It will also improve the ability of the patient to participate in physical activity. Priority problem 2, excess fluid volume related to water retention and use of diuretics, as evidenced by shortness of breath, weight gain, hypertension, and respiratory distress and edema. The reason behind is that excess fluid volume can cause serious side effects, so it is a priority to treat excess fluid volume to prevent long-term damage. Retaining extra fluid makes the patient feel bloated and uncomfortable. Excess fluid volume can increase blood pressure, which results in heart working and harder to transport blood. Over the time, heart gets weaker, which results to various heart problems. So it is essential to treat excess fluid volume, as it helps to lower blood pressure and heart rate and helps to relieve respiratory distress. Let's discuss the planning. Priority problem 1, short-term goal. The patient will deny any difficulty in breathing and maintain a normal oxygen saturation, respiratory rate, and depth within 4 hours of admission. Long-term goal. The patient will demonstrate breathing techniques at the time of discharge to improve her breathing pattern and ability to do all activities without having shortness of breath. Planning for priority problem 2, short-term goal. The patient will be euphonic and maintain electrolyte balance, as evidenced by ease of breathing, vitals within normal range, and resolution of edema within 48 hours of admission. The long-term goal: at the time of the patient will verbalize awareness related to causative factors and symptoms of excess fluid volume, and plain measures that can be taken to prevent and treat extra fluid volume. Let's discuss the intervention. Intervention number 1: maintain patent airway and administer oxygen as indicated by the patient's symptom. Administer diuretics such as furosemide as prescribed by the healthcare provider. The rationale behind is that instructing the patient regarding effective coughing technique will help to move secretion, which will assist in maintaining patent airway. And the supplement oxygen will increase the oxygen supply to the body, which will help to relieve respiratory stress. Moreover, diuretics are the first line of drugs for patients with fluid overload. Diuretics reduce blood volume, which decreases venous pressure, peripheral edema, pulmonary edema, which helps to relieve symptoms quickly and control fluid retention. Intervention number 2: provide health teaching through discussion and handouts to the patient regarding the pathophysiology, causative factors, and symptoms of fluid volume stress, secondary congestive heart failure. Instruct the patient on lifestyle changes such as fluid and sodium restrictions, monitoring intake and output, elevating extremities, oral care every 2 hours, and weighing herself daily and comparing it with the previous reading. The reason behind is that health teaching a patient regarding causative factors and symptoms of the excess fluid volume is necessary to make lifestyle changes. Also, providing education regarding fluid and sodium restriction is essential, as a restriction of sodium and fluid helps decrease fluid retention. Monitoring intake and output enhance compliance with the regimen. Also, elevating extremities help to reduce edema, as it increases venous turn to the heart. Moreover, oral care will help to elevate the sensation of thirst without an increase in fluid. Also, monitoring daily weight is essential, as an increase in weight indicates fluid volume excess. Let's evaluate our priority problem 1, evaluation of short-term goal. The patient denies any shortness of breath and maintain normal oxygen saturation, respiration rate, and depth within 4 hours of admission. Evaluation of long-term goal. The patient demonstrated breathing techniques at the time of discharge to improve breathing pattern and the ability to do all activities without having shortness of breath. Evaluation of priority problem 2, evaluation of short-term goal. Within 48 hours of admission, patient is euvolemic and maintain electrolyte balance as evidenced by vital signs within normal limits, ease of breathing, and resolution of edema. Evaluation of long-term goals. At the time of discharge, the patient verbalized awareness related to causative factors and symptoms of excess fluid volume and explain measures that can be taken to prevent and treat extra fluid volume. Here are my references list. Thank you so much.